So, December 31st, the few, the proud, we are here, we are working.
Yeah.
So
let's talk a little bit about the last year at Inspired Spine and what we have in the future for next year.
sounds great to me.
What does Inspired Spine do that others don't?
Well, I think Inspired Spine is one of very few private healthcare delivery system that does research, innovate, and truly every month we have something new. Every month we are better than the last, and we truly have a core group of people. We are agile. If we see something can help our patient better, it will not take us years to act on it. And we have the most incredible data collection. They talk a lot about evidence-based medicine. Unfortunately, medicine has become eminent-based medicine, meaning somebody is famous and everybody just follows, rather than truly, genuinely looking at the data, see what you did, and reevaluate what you do. And I can just recite a poem from my favorite, one of my hero poet, Maya Angelou. Says, "Do the best you can until you can do better, then do better." And this is what inspired this. We do the best we can, but we constantly strive to do better, and then we do better every month.
One of the big things that you guys have done this year is develop your new sacroiliac. Can we restart?
No, it's a
your-
sacroiliac joint.
Yeah, I want to say your new Trident
Yeah.
screw instead.
Yeah. Okay.
Okay. So you don't have to restart it. You can restart.
No, did you restart
I can
mine?
crop them
I
together.
left
easy.
that one. I left yours going.
No,
That's
don't-
fine.
let
Okay.
it go. I cut it out. That's
Okay.
I can cut it out too.
yeah.
I'll set
Okay,
this one.
so one of the big things that you guys started this year is your new Trident joint screw. Do you want to talk a little bit about that?
Yeah, absolutely. I see many of our patients, they go years from spine surgeon to spine surgeon and they are told there's nothing wrong with them. It is like you have kidney problem, you go to heart specialist and he says nothing wrong with your heart. We know it's nothing wrong with your heart, it's the kidney. Same with the sacroiliac joint. Many of these patients, the lower back spine and the sacroiliac joint are so close to each other. Symptoms are very similar. As a matter of fact, we call the sacroiliac joint the chameleon joint. They go years and they are told is nothing wrong with them. They doubt themselves. And then when they come and we truly diagnose their sacroiliac joint, they're not crazy. It's just nobody looked at where the problem is in this sacroiliac joint. And we put them through specialized diagnosis. We do a conservative management, then we do a 20-minute procedure with Trident, and literally they come back and they want to hug me because they were told they're crazy, and they are not. And that's the point. If you're not trained to diagnose that, if you don't include that, you will label this patient as pain seeker, and they go through a life, years of misery, and everybody tells everything is all right with them because sacroiliac joint, you cannot see the disease on a picture. You have to do certain diagnostic. You have to provoke the joint. You have to numb it up and see how much of the pain goes away. Most of our spine surgeons, we are used to look at the X-ray, CAT scan, MRI, and sacroiliac joint is not diagnosed that way. That we miss it a lot. So this year we brought the Trident. It's FDA approved and we use it. We made a 1-hour surgery, a 15-minute procedure. We have done plenty of that and the result is incredible. This patient go home within an hour or an hour and a half. So we are hoping to give lots of people improvement in their life in 2022.
You mentioned the time of the procedure. On LinkedIn, you get a lot of negative feedback when it comes to your speed of your surgery.
Yeah, I see some people pride themselves they are maximally invasive surgeon, as if there's anything to be proud about. We know based on hundreds of thousands of studies, population that are in the studies, that every additional half an hour under anesthesia, every additional 30 minutes under anesthesia adds 17% to the combined risk of the surgery. These patients are sicker, it takes them longer to recover, they have more heart attack, pneumonia, more dying of those surgeries. So we made a 7-hour surgery, 1-hour surgery, and I get lots of heat from, it's not about the speed, we are kidding ourselves. longer surgeries are more risky. We know it based on any other kind of surgery we have done. Talk to an anesthesiologist, they tell you how a patient recovers after a 1 hour surgery versus a 7 hour surgery. I think misconception is here that we are speeding something up, that we are not fast, we are efficient. Like, you will never say an airplane is fast because it goes in 1 hour from Minneapolis to Chicago. It's efficient, it's that the speed airplane flies. Now, if you take a car and which needs 6 hours from Minneapolis to Chicago and you drive it in 3 hours, then you are cutting corners, then you are dangerous. But see, many people cannot wrap their head around that this is a different mode of surgery. What do we do 6 hours in an open old-fashioned spine surgery? We cut because bleeding, then we cook the tissue to stop the bleeding, then we continue, and this goes on and on and on and on for hours. Imagine you just take all of that away and just go exactly within 5 minutes where you need to be. So we are not fast, we are efficient. And when people come and see us, they understand that, but unfortunately, lots of people, especially people who don't want to learn new techniques, they cannot even wrap their head around how do we do a surgery they do in 7 hours in 1 hour. But when they come, they see it's incredible, but it's not, we are not trying to be fast. It is just, the surgery is very efficient because it uses different kind of technology.
You share a lot of your data on LinkedIn. Is this an accurate representation?
Yeah, we are. When I started this endeavor, when I went to Georgia, Atlanta, Georgia, and I saw OLLIF procedure, transcameral OLLIF procedure, my jaw dropped on the floor. I was already trained for 25 years, and my jaw dropped on the floor. But I knew it's a difficult thing to wrap your head around if you haven't seen that. And I knew that, it's not enough for me to do that. I need to spearhead it, because if not me, who? But I knew that I need two things: data. So I started very meticulously gathering my data. Like, I can't tell you in 1 minute what is my average hospital stay or blood loss on 2-level OLLIF in 2015 in my female population between age of 30 and 35. So we have done a meticulous data collection, but I knew even that's not enough, As every surgery, every procedure, medicine is not an exact science, it's an art, it has a soul. I knew I have to capture as well the soul of this. What I noticed about 2 months into this, I actually start seeing the patient coming back to me. They are telling me they can walk and they can move and their leg pain is gone. I am, as a trained surgeon, I'm trained to cut people open, literally massacre their back, fillet them open to fix them. That is how I learned that, and I couldn't believe I don't have to do that to make them feel better. So I knew if I'm doing it. It's hard for me to believe that. I knew it's hard for my colleagues to believe that, and I knew, as we know, cold data is not enough. So what I did is I took my time in my busy clinic. I took testimonials. You see all those shaky testimonials, and we have 1,500 of them. Probably close to thousands are online on YouTube. Everybody can look them up. You see patient after patient, they have tears in their eyes. They come, their leg pain is gone, their back pain is gone, they regain their life, they're off narcotic, with a surgery that is sometimes 35 minutes, skin to skin, and we fix them and we send them back to their life. And I try to capture not only the data, but as well the soul of this. This is an art, this is not medicine. Lots of especially young surgeons try to culminate all we do in numbers, like, what is that angle? What is that, how big is that screw, and so on. But behind every surgery is a person. And I wanted to give those patients a voice. So I tell many of my colleagues, they say, if it works, I say, here's the data, and here are 1,000 patient testimonials. They say, I woke up, my leg pain was gone. They say, I regained my life. They say, I could walk again, and so on. So whatever we see, that the amount of the evidence we have gathered is above and beyond of what would be necessary to show what we do is really working.
So it seems like OLLIF has a lot of really great benefits.
Mm-hmm.
What would you say is the greatest benefit that OLLIF has to the community?
See, when you have pain, it's not, you don't have only pain for yourself. Your whole family. If you know you're in pain, your whole family stop doing what they do.
Yeah, you can't really function
Yeah.
together.
Yeah, and and I know that whole family, they just turn time to take time off work to help their mother, because the mother cannot function. Now imagine you put that mother, we got a testimonial that this poor lady for years have been told there's nothing we can do, you'll die of surgery because you are 85 years old and you need a 10-hour surgery, correct your scoliosis. You cannot have that. She said, if I die, I die. I cannot live like that. And the family, they were taking turn in taking time off work, and I have that on testimonial online. After surgery, they have to call her to see if she has time to see them, because she's active. She's she's getting together with her friends and so on. So, and that is the impact on the community, as well as returning back to work. We had a truck driver, and not that I recommend that, but he said, yeah, I took few days off. I did the surgery Thursday. He went back to work next Tuesday. So 5 days, 4 days. And that's a truck driver. You cannot wrap your head around that, what is the difference between this and open surgery, where you are practically, if you have a demanding job, 6 months to a year off work. Because amount of the damage you do is tremendous compared to what we do.
Why aren't universities teaching this procedure?
You see that I'm asked this question a lot, as if universities are always the first thing to adopt new technologies. From every tremendously beneficial technology we know, most of the time universities are the last to adopt it, like endoscopy, right? When you go you remove your gallbladder, they make small holes. I remember I was still in the med school where they would cut you open, literally put all your guts out to take your gallbladder out. Universities did not brought endoscopy, and they weren't the first to adopt that. Few truly passionate, truly motivated individual, they made it happen. As a matter of fact, universities has been the last to adopt that. I actually have a testimonial with Dr. Maurer, who is a general surgeon. He's going to retire soon. He went through that process with endoscopy and laparoscopy and abdominal surgery. And that testimonial is out there that you should watch it, that the amount of the resistance it was displayed to prevent making small incision to do that surgery rather than just cutting your gut open and do that surgery. When I ask this question, I always see the assumption that universities, all this good stuff coming from the universities. No, I have to say that in 2013, I went with my data to the chair of neurosurgery, University of Minnesota. I showed them the data. I said, even if 1/3 of this is true, I had preliminary data, I haven't published that yet. I went there and I told them, even if 1/3 of this is true, this is something we have ethical duty to bring it out there. He looked at my data, the chair of the neurosurgery then, and said, yeah, we don't have time. When you publish, come and talk to us. And I approached them 7 times. They always say they don't have time. And I have approached many universities. They say they don't have time. And you made a comic about that. Actually, I love that comic. Yeah, on the board, they do a surgery that I do in 40 minutes in 7 hours. And then the comic comes out that sure you don't have time because you are not efficient enough. So universities, unfortunately, have come to a place that you want to raise the least amount of wave. there's a very good book. It's called Black Swan by Nassim Taleb. If anybody thinks universities are where major things happen, go there. Why do you think that Bill Gates or Mark Zuckerberg, they stopped going to the university and went and built this humongous industry? Why is it that's a concept that we know again and again, that this individual, they go to academic and see how, like a mammoth, like a dinosaur, how they move. So what it makes that they come out and then they go truly achieve things is that they are not shackled by this polity, by this small kind of it fights what always happen in the university. So long answer to your question, and the answer to that is the status of the development is always that a few individuals do that, and universities eventually catch up, but they're never first to adopt.
You also face resistance from some of your colleagues. Why do you think that is?
Well, let me talk to you about one of my colleagues I work with, Dr. Kim, who says he was maximally invasive surgery. He's working with me, for a good reason. In surgery, we are very conservative, meaning that we are careful to do new things because the price on the patient can be big. It took me 4 years to show him, prove to him that this is a game changer. He's like the Saulus become the Paulus. The Saulus used to kill Christian, and he became the most important apostle for Christianity, brought Christian faith to Europe and to Rome. He was the person who says small incision doesn't work, but he saw over 4 years that it not only works, it works so much better. Patients now he's doing a multi-level fusion with OLLIF in a surgery center, and he cannot believe that it took him so long. Once you see the result, once you feel the results, but you have to see and feel the result. You have to have the curiosity, not just staying in the back and throwing stone, but you have the curiosity to say, I want to look at the data. Now in Lincoln, again, lots of people say, I don't believe in this, I don't believe in that. You know what most of the answer to them is? What do I tell them?
You always say, look at my data.
Let me show you my data. Let come be critical. Let me show you my data. What do they say?
They don't even reply.
They just take back. They just step back. So it's not, there's that curiosity that, is it really true? They don't go the next step. I think my blessing in 2012 was, I said bullshit. I don't believe that. But I didn't stop there. I said, bullshit, I want to go and see it. And that's what I did.
So I'm going to ask a few questions about the OLLIF procedure itself. Do you use robots?
Well,
or lasers?
Yeah, well, laser like Star Wars.
Yeah, exactly.
So, see, laser sounds good. There was this Laser Spine Institute. They just used the laser, and I talked to many of them. They just brought the laser, turned it on and off, and took it off, so they can't say they used it. Laser practically was used in 1970s and 80s. Instead of cutting the herniated disc, vaporizing and then sucking it out, it didn't work. In 1996, when I started my residency in Germany, we had a laser machine that was collecting dust for 8 years in 1996. So we know it doesn't work, it's just a gimmick, and we know that they went out of business, that lawsuit, we know it doesn't work. Let's talk about robot now. Yes, I do use very expensive computer and robot. I use the best computer in the entire universe, and that is the computer between my ears. And I use the most advanced robot existence in the history of humankind, and these are the arms that are attached to my shoulder. You just have to hone them, you just have to train them. One of the things that we are talking now, we are creating a work group with surgeons all around the world. Everything you do, you get 5% improvement, and you have to pay $5 million machine to do that. All you need is train. See, this is weekend for most of people, but we are here. We are working to make it happen. You have to train your arm to your skills. And I tell, we had a conversation on LinkedIn that I criticized the robot, and especially people from the industry, they went mad. They want to sell their robots. I want to make my patient feel better. What I told them, I did a PhD in computer science. I built those navigation machines. I programmed them. As a matter of fact, I started a PhD. My dissertation was computer-aided surgery in 1993 until 1998. I know anything need to be known about those robots, but now instead of that, I use 2 C-arms and my skills. Because once you get to the bottom of it, somebody just right of high school have written those algorithms. We think these computers are tremendous. A cockroach has more computing capacity than our most advanced robot. And what we underestimate, the capacity, the amount of literally computation that goes inside of our brain. So yes, I do use robots and very advanced computers between my ears.
Do you use endoscopy?
See, yes, let's put it this way. Most of the time, lots of people use endoscopy are from orthopedic colleagues. Neurosurgeon, I'm a neurosurgeon, we used 40 years ago, start using microscope. And where neurosurgeon used the microscope, most of the orthopedic surgeons use their eyes, so they had to do bigger opening. So generally, neurosurgeon use smaller opening than the orthopedic surgeon for that reason. Because we grew up in the residency with the macroscopic techniques and so on. And even 20 years ago, our incision for macrodiscectomy, they were 1 inch, 1.5 inch. Now, comparing to open surgery, doing surgery with the incision about 1 inch is a tremendous advantage. But for a neurosurgeon, that's not new. Now, the macroscope does 2 things for you. The macroscope magnifies, but that's not the most important part of the macroscope. Imagine I want to look on the bottom of the small tube to the anatomy of the patient. The macroscope brings the axis of my eyes closer so I can look 3D on the bottom of a tube. So I do macrodiscectomies with the macroscope. By the way, an endoscope is maybe $30,000, $50,000. A macroscope is $500,000 machine. So I'm using a more expensive machine, and I have 3D vision, whereas endoscope has only 2D vision. Additionally, with the microscope, I have literally have everything. I don't have to hold it; it's hold itself, so I can use both hands. Where with the endoscope, most of the time, one hand is just holding the endoscope, and we are like a one-arm bandit trying to manage everything with just with one arm. Only in very specific situation, endoscope may have an advantage. That's when you come from further out, almost from the flank, because macroscope, the tubes that go that deep, they don't let you work well. But beside that, for neurosurgeons who have been using the microscope for 40 years, I don't see any advantage of endoscope. Actually, just yesterday I talked to somebody in New York, and they brought the endoscope. They looked at it and said, nope, it's not adding anything. And they went back to their macroscopic kind of treatment. So in certain situations it does that, but everybody trying to have a reason why they are better than the others. It used to be laser, now is the endoscope. We do those surgeries. Our incisions are about 1/2 of an inch, and our patient going home, but we have been doing it for 40 years, so it's not a really new thing.
Okay. Can you achieve adequate decompression with this procedure?
I hear that a lot. Especially not in the most of the time in our spine. If something push on the nerves, that is what gives you pain. And back pain, you're too young to know that, but I have had back pain myself. It can be really horrendous. Most of the time, it's something pushing on the nerve. We want to take that pressure off. 9 out of 10 times, what's pushing on the nerve is the content of our own disc, that it's not like I tell my patient the disc is like a tire of a car. Imagine you have a flat tire. The rubber that bulges out pushes on the nerve. What happens if you jack up the tire? Tire looks normal. The pressure goes away and the tire doesn't bulge out anymore. Another thing is that, there's a concept of direct decompression, meaning that we go and cut the bone away so that the nerve is not sandwiched between the disc and the bone. So direct decompression is cutting the bone. And then the concept of what most of my colleagues call indirect decompression, where you restore the height of the disc like jacking up a flat tire, and then the tire is not bulging out anymore. And we stopped using that term indirect decompression because nature right now, you don't have leg pain. No, you don't have leg pain because the distance between the discs are maintained because you have a good disc. It is physiologically, you don't have any pressure. So we are restoring back spine of the people to how their anatomy used to be or supposed to be. We call it physiologic decompression and anatomic restoration rather than indirect. There's nothing indirect about making your spine normal again. And there is a big question, is it enough or not? Well, I can show you the data, but they don't want to look at the data. I can just tell you, go watch one of those 1,000 patients who wake up. The moment they wake up, the leg pain is gone. And I can give you lots of, the physiologic reason, anatomical reason that if you lift up 2.5 millimeter the interdiscal space, you're doubling the area of the area where the nerve root is going out, and so on and so forth. I can give you lots of explanation, but I think all of that is irrelevant. When the patient wake up and they say their leg pain is gone, we are, again, surgeon, we are physician. Our job is to make the patient feel better. Can we do that? I have the data. I have 1,000 testimonials. So, and the critique that comes is legitimate, but it is just a fake critique. It's a fake interest. If I tell you, come and look at my data, and then you just back off and go and don't listen to that, where I give them the opportunity to come and look at the not only data, clinical data, but as well look at what the patients say. So I'm a little tired actually of that fake intellectualism, elitism. I just want to say something because I think I'm important. But when it comes to truly spend the night, like last night from 10 p.m. until 2 a.m., I was looking at my data. Okay, so you have to walk the walk. And many of these people, they just have a concept. They are not really interested in the data. But if somebody is interested in the data, contact me. And I show you the data.
Okay, and my last question about the procedure, it's OLLIF with 2 L's, and then there's OLLIF with 1 L.
Yeah.
What is the biggest difference between the two?
So, you see, the Lord did a mistake. Sorry, Lord. He put the spine exactly in the middle of our body. There's no good way of getting there if something is wrong. It is like putting the most important part of the car in the least accessible part in the place in the car. And you have to get there. You can fillet the back open, and and the standard for that are 70 and 40 years. We are using standards nowhere else. We are using standards that are 70 and 40 years. I read a really nice book. It was about the half-life of facts. It's about that how our knowledge rejuvenates itself. The half-life of facts are 7 years. In 7 years, the entire humanity moves forward, but yet we are using 70 and 40-year-old standard to treat the spine. For that reason, we have created new ways of getting that, like opening up your belly. If everything goes well, it's better than going from the back, but lots of things can go wrong. As a matter of fact, here in the University of Minnesota, they shut down their anterior approach, we call it. They shut it down because people died, okay? And those people in the university who are criticizing me, I asked them to come and look at my data and I will look at their data, I'm still doing OLLIF. They shut down their anterior approaches because people died. So if it works well, it's better than from the back, but there's side effect. Now, there's a OLLIF, what we call ATP, OLIF ATP, where literally we go from the side instead of from the front, but still patient is on the side. You still have to go through the belly. Again, if it goes well, it's a good surgery, but you have to go through the belly. And there are some other approaches, go from the side and so on. So each of them has its own legitimacy. And I think we should look at many different approaches to treat the patient. But I have noticed that by gaining experience, I can do most of the surgical situation. I can manage them through the what we call transcambient OLLIF with double L, whereas OLLIF with one L, we still go through the belly.
Another big thing you guys have this year is your university you're opening, ETU.
Yeah, I'm proud of it.
Can you tell us a little bit about Avicenna Tech?
Well, thank you as well to you and your group for that. I just can recite, well, everybody has his heroes. For some people is the Doja Cat or little something and so on. My heroes are Richard Feynman and Max Planck. Max Planck was you have a cell phone, we are recording this on a cell phone. We have a light, LED lights and so on. Everything in every technology works based on quantum physics understanding how electrons are acting. And Max Planck is the father of quantum physics. This quote is from 1906. He says, "Science advances one funeral at a time." Because he had difficulty to make the universities to accept his truly new concept of how nature works. Without quantum physics, no cell phone, no lights, no telephone, no TV, nothing. We're still cooking on wood. He's the person who said a new scientific fact doesn't come to get accepted because all of a sudden the opponent believe in that and adopt it. They just die out and the new generation grows up with a better way of doing things. Now, I tried to approach other universities and nobody want to help me to teach it to people, and I'm passionate about that. I hope people who meet me understand how passionate I am about that. So I think all is left for me to build my own university to teach it truly to people who are interested, especially people in other countries. Because yeah, we still can get other surgeries, like open 7-hour surgery, and we have good anesthesia, we get 5 blood transfusion, we still can make it. In other countries, you literally have to live with the pain or die with the pain if you have this problem. I want to make sure that the poor guy in India can get that 1-hour surgery and go live their lives. And because they cannot get that big surgery. Or a 85-year-old person who has been told by 5 surgeons here justifiably that you cannot have that surgery because you will die of that surgery. The surgery is too long and you cannot tolerate that. Now all of a sudden you get a 40-minute surgery. I did a surgery on a 95-year-old person with a grade 2 spondylolisthesis. Nobody would in their sound mind do a 4 or 5 hour surgery. I did a 33-minute surgery and I discharged him 2 days later and he was ambulating. So, or people who are big, we had this, every person is proud of a certain moment in their lives. I was proud of myself when I had tear of joy in the eye of that patient's mother.
Which patient?
That the 500-pound patient with the BMI of 62 that a panel in Cleveland Clinic told them he cannot have the surgery justifiably. We did that surgery in 1 hour and 54 minutes. I sent a patient out of hospital 2 days later, and you see the mother says, "I see my son walking again." Okay, I have to teach it, and if universities don't want to help me, that be it. I built my own university. See, Elon Musk is not my hero, by the way, but what I admire about him, he saw it was hard to pay online. He didn't just accept that. eBay, PayPal, an online platform you can pay people. If there is a problem, you can't wait until other people solve it for you, or you go and solve it. So ATU is, or Avicenna Tech, is my answer to not having the right partners to teach it. By the way, Avicenna is a Persian polymath in about 1,000 years ago that actually discovered alcohol and lots of like schizophrenia and so on. So he was his book Canon of Medicine was taught until 200 years ago in major universities, and for that reason, we named it Avicenna Technical University. And technical because we want to teach them things that they can really do next day. Like my preferred motto there is, we teach you in the morning things you're going to use in the afternoon. So I'm proud of it.
And part of your ATU curriculum is a soft transition. What does that mean, soft transition?
Yeah, so a dirty secret of the spine surgeon or all surgeon is that once you're done with residency, you get so busy, you have to take really time off, go learn new things. Most of the time it happens, you go to a weekend course, you do a cadaver lab or two, and then you go back, you perform it on the patient, you shush about it until you get good at it. And we know all that your result in the learning curve is sometimes horrendous. And most of the time we get by because things are similar. Things are just 5 or 10% different or better. Now all of a sudden, if something is so different, your previous knowledge doesn't apply. That is why lots of people don't want to take time off. They say you cannot teach old dog new tricks. There are lots of old dogs in the spine. And not only they don't want to learn new trick, they cannot learn new trick. They don't have time to learn new trick. They have to take time off, go back to school, learn that. Because if it is, I compare it to driving a car versus flying. You can be the best driver of a car, you're still not a pilot. You have to go learn certain things from scratch. It's so different. By the way, the general surgeon with endoscopy went through the same process. About almost 95% of the people who try to just go to a cadaver lab, come back and do it, they had bad result, they quit doing that. Because this is so different that you need to have exposure in a controlled situation. By the way, residency is the same. You go to 7 years residency, you learn something in 7 years. How do you expect to go to a weekend course and come back? Now we are trying to replicate that residency in a controlled way. So practically, we know now everything needs to be known about what can go wrong, how things can go wrong, how you can do better, and we want to teach it to a new surgeon. That's what the soft transition is, where they pair with somebody who does it, and we practically help them to have post-learning curve result from day one by stage-wise, literally bringing them to the table. Like at first, we have a conversation, the intro, we talk about the theoretical, like when you go, I'm a pilot and I use lots of, by the way, I'm a better surgeon than a pilot. You know what I'm talking about.
Yeah.
But I had a crash, that's what it is, and the airplane crash. But I learned that from piloting. First there's a theory, then literally when you go flying, your instructor takes off. He does most of the flying. Once you're in a safe altitude, he let you maneuver and so on. And little by little, you do more and more until one day he let you land, and one day he just take off from the cockpit and says, go for a run and come back. You don't even know when you acquire. We know from lots of studies like FAA want us to have 20 takeoff and 20 landing before we can have our licensed pilot. It seems that human brain need about 40 experience, and we are trying to, based on science of learning and teaching, to recreate that. So we have theoretical part, then we have a cadaver lab, then we have a literally a second cadaver lab, and then the observation, then we gather the cases. Then I go actually have my license in 5 states and in many hospitals. I just came from El Paso. I'm going to Michigan. I go and scrub in and I make sure the patient get the best care and the surgeon get the best teaching. And by the way, by condensing that, by doing it that way, we know in how to dose the knowledge for them to have the best learning experience in totally safe environment. So that's what the soft transition is.
Thanks, and that's my last question for this segment. Now I'm going to move on to more of a segment for patients.
Mm-hmm.
So what type of patient is a good candidate to receive the OLLIF procedure?
Well, we talked about that spine problems are common. As a matter of fact, by the time you're 50 years old, 70% is likely that you have spine problem. By the time you're 70 years old, there's only 2% chance you don't have spine problem. We have developed these very specialized protocols to help anybody can be helped with other means. But if the disc is literally like a tire that has 20 holes and cannot be helped anymore, that is when you need a fusion. And when you need a fusion is when OLLIF can help. OLLIF can, with a small incision, less than an inch incision, go there, take the bad disc out, replace it with a spacer so the bones are not grinding each other. And then over multiple small incision, we put screws in and stabilize your back. That's why my patient can walk 2 hours after the surgery. They go home 90% of them within the first 24 hours after the surgery. Because we restore the height of the disc, take the bad disc out. So if the disc is beyond repair, that's when the OLLIF can help you.
So other procedures, it seems like, have limitations based on age and BMI and things along those lines. What are the limitations when it comes to OLLIF?
No, let's talk about limitation as general. We talked about that. Spine is unfortunately in the middle of our body. We have to go through other tissue. It takes time. We have to stop the bleeding, and it has to cook the tissue that create infection and so on. But culminating it all together, we published a paper, and there are tremendous number of paper out there that show it is about everything correlate with the time under anesthesia. Like surgeries that are less than 2 hours are half as risky than surgeries that are more than 2 hours. Every additional half an hour under anesthesia, 17% to the combined risk of the surgery. And we did a study actually that in all these surgeries, if somebody is bigger, you have to go through more tissue, so surgery is longer. And surgeries that are more than 3 hours are exponentially dangerous, especially to elderly people, people with comorbidities like diabetes and so on and so forth, because you cause too much damage. You're doing something and that's 7 hours. What you're doing is damaging the tissue. It seems that the time under anesthesia is a big factor there. And what OLLIF can do is make a 7-hour surgery, 1 hour surgery, a 12-hour surgery, a 2-hour surgery. So as a matter of fact, 99% of our surgeries, more than 99% of our surgery under 3 hours, 94% of our surgeries are under 2 hours, and 45% of our surgeries are under 1 hour. So for the first time, we made this big surgery, small surgery, so we can give it to more people. We can give it as well to make it a surgery center, especially with COVID, There's no bed. Well, we don't need beds because we send them home same day. There is, and even if they have to stay in the hospital, they stay in the hospital just 1 night, not 7 nights. Like average hospital stay in Minnesota is about 4.2 days. In some hospital, like Health Partner Hospital, is 6.2 days. Ours is 1.6 days. This is publicly published data online, and everybody has access to that. So, and this is the limitation of all surgeries. How much damage, risk versus benefit. Now, there are some patients that if the patient cannot have a half an hour surgery, well, they are not a candidate for OLLIF either. If they cannot get cleared for anesthesia, they cannot have any surgery, period. But percentually, we can offer it to more people than any other procedure. Now, there's very special situation when the problem is so bad, like, I'm talking about, the multiple curve scoliosis with a Cobb angle of 70 degrees and so on, that you cannot get the right angle for OLLIF. But those are extremely rare cases. I would say probably for more than 90% of the patient, OLLIF is not only the best solution, but it should be the first solution.
Because you do minimally invasive scoliosis correction
do.
with OLLIF, and you did it on a Jehovah's Witness?
Yeah, I did on Jehovah's Witness, where 4 people said she cannot have because they said she will lose so much blood that she cannot have the surgery without blood transfusion. And we lost like 1/3 or 1/4 of this cup of blood. We just lost 110 cc of blood and sent the patient home next day.
And then my last question that I have for patients is there such a thing as too soon to seek treatment for your back pain?
Well, treatment, we talked about that, this is a common problem. No, it is not. That treatment doesn't need to be surgery, doesn't even need to be physical therapy or injection. Sometimes that treatment is just getting the knowledge, education, and understanding about how your spine works and how you can put you on a good path versus the bad path. Now, here we have this essence stuff here, and you're part of the IS Life. This is actually why we have the IS Life and Essence. Is about healthy living. It's about showing the patient like yoga or healthy exercises, healthy diet, and so on. In that sense, if you include that in the treatment, and it is a treatment, knowledge and education and is a treatment, no, there's never early to get treatment. I think you should get treatment for your spine when you're 12 years old, because when you have a healthy spine, you can, it takes more for you to become symptomatic. So I think everybody should get involved in the healthy spine management by the time they are teenagers. And that is a job actually you and your team are doing. So thank you for that.
Thanks. Okay, I'm done with this section. The next section is actually the future of spine.
Yeah.
So you've referred to OLLIF, or I have referred to OLLIF as the future of spine. What exactly does that mean?
Let me just recite something from a book. It's a book on minimal invasive techniques. And in the book, which was published about 10 years ago, it says they are talking about the minimal invasive surgery and general surgery, not about spine. Spine is 30 years behind it. They say the importance of the minimal invasive surgery in the spine, in this general surgery is as important as antibiotic. We could not do surgery today in 2020 or 2022 without antibiotic. Meaning that it is such a standard thing that we cannot even imagine. Another thing they say is that imagine our gallbladders had to stay 4 days in the hospital. That would break down our healthcare system. Now, flashback, news for you. Spine is breaking the backbone of our healthcare because more people get spine problem because people getting older, the population is getting older. We don't have the capacity to help them. Something majorly to happen. That something majorly is not having another $5 million robot in the OR and that replace my skills. That something new is making a 5-hour surgery, a 1-hour surgery. Making a surgery, open surgery has 3 to 5 in complex cases, even up to 8% risk of infection. And if you see one of them, you never want to see another one. They have 5% risk of infection. Ours is 0.2, 1/40th risk of infection for the open surgery compared to the open surgery. Not a single take back. Something majorly need to happen, and that is for people to get treatment in a way that is they can recover better, has lower risk, and we can provide it because more people are going to need that. We can provide it to more people. So people are getting now 90-year-old, no problem. Imagine if the last 20, 15 years of their life is just pure misery. This is what can be. Open surgery has no solution for that. We do.
When you look at the new year, look into the new year, what do you see coming of the spine industry, the spine care industry?
I think the awareness is going up now. Many of these companies now truly understand what this is and start getting on the bandwagon. But we just developed, and again to you and your team, we developed a work group for India, Pakistan, Middle East, and we are going to bring this technology as well to other places where hopefully they can just bypass all this robot and so on and go to what really matters, surgeon skill and delivering that. I think I can just recite that Star Wars movie, The Force Awakens. 2022 is where the force of the understanding what really matters in spine going to awaken. And I'm going to do my part. And we have good people doing their part on that.
My last question in this section is, what advice do you have for the spine surgeons of the future?
I can tell you from my experience, I was trained in so many, I didn't have a normal residence, a normal med school is about 4 years here, and then you do pre-med before. In Germany, you combine it. I had 7 years of med school because pre-med and med school are combined. Then I was in multiple hospitals in Germany. Then I was like in 20 different hospitals or more here in the United States. I was trained under 150 attendings. And I had the 13 years residency. The benefit of that is every attending, every teacher gives you a set of tools. If you have more tools, you can combine them and do extraordinary things. So I was lucky. So I had so much experience and tool in my toolbox that I could come with solution for problems that somebody who just went straight from med school to 6-year residency or so may not have. And the future and my advice to people is get as much experience you can with as many people as you can. Like, I'm a neurosurgeon, but many of my technique I learned it from orthopedic surgeons. Like I learned, we neurosurgeon, we take a high-speed drill and we brush on the part of the bone we call facet. It takes us 15 minutes to do that. I learned it from orthopedic surgeon that you can take a chisel and take it off in 20 seconds. So I think you cannot wrap your head around, if you just have been in one school of thought, to things outside of the box. So be outside of the box, learn new things, learn things from people who are not in your discipline, because everybody in your discipline is by definition inside of the box. So I think the future of medicine and what I advise to new surgeon is look outside of what you have been taught, because that is where future is going to be, outside of the box. Like not only medicine, everywhere. Like, what is special about Google? What is special about Facebook? What is special about TikTok? What is special about Apple? What the common sense, common thread there is that they all thought outside of the box.
Okay, thank you. Is there anything else that you wanted to touch on?
No, I actually, I'm literally looking forward to go to the new year with new energy and make it the year that really big things are going to happen. I'm really looking forward to that. Thank you.
Thanks.